afternoon, everyone, and welcome to the 43rd installment of the Stop COVID Deaths webinar series. Palapit na po ng palapit ang ating one-year anniversary, and we are really glad and happy that you choose to join us in this learning journey as we continue to address your concerns about COVID-19. Our discussion for today was our opening remarks speaker, I believe, during webinar number 27 last year. And he remarked that health is not only linked to economy, health is economy. And his presentation was met with a lot of requests, and we are now, due to insistent public demand, bringing him back, but now as our main discussant for this afternoon. So the COVID-19 pandemic po, it magnified the unacceptably low level of investments in the public health system. So when this pandemic started, we didn't have any testing labs, bed spaces, or even personal protective equipment for an outbreak of this magnitude. At the heart of this crisis was a shortage of health human resources. And embarrassingly enough, we had allocated relatively low wages po para sa ating mga frontline health workers compared to other countries, especially our neighboring ASEAN siblings. Magandang hapon po ulit. I'm Dr. Raymond Francis Sarmiento. Masaya po kami ulit na sama-sama po tayo ngayong hapong ito para sa webinar number 43. And always, I'm very glad to share hosting duties with my partner in crime and my mentor, who is the Special Envoy of the President for Global Health Initiatives, and also our adjunct research faculty at the National Telehealth Center, Dr. Susie Pineda Mercado. Dr. Susie?
Hey, Raymond, kamusta ka na dyan? Good morning, good evening, good afternoon, everyone, and for everyone who's watching on the playback or those who are watching on Facebook or on YouTube. Magandang araw sa inyo, naimbag na adlaw, mayad nga adlaw, maayong ugto. Hello, everyone. I'm looking at where everyone's coming from. There's a shout out here from UP Open University, Quezon City, maraming nanonood, Surigao, Bohol, Aklan, Pasay, Iloilo, Negros Oriental, Albay, Tacloban, Leyte, marami pa po. Welcome. Thank you so much for joining us today. We have a very important topic. Pag-uusapan po natin yung sahod ng mga healthcare workers. We're taking a little bit of a break from our discussions on vaccines, but not really, because we have a video message for all of you. TVUP, please go ahead.
Ako po ay nagpabakuna na. 2 araw na. Wala naman po ako naramdaman.
I feel great now. I had some fever yesterday afternoon, slight fever, yung sinat. So happy naman ako doon because that means the vaccine was kicking in.
Kaninang hapon po ay nagpabakuna na po ako ng Sinovac sa Philippine General Hospital.
Observe ako for 15 minutes kasi low risk ako. And then after 15 minutes, pinauwi na kami.
Parami na po ang mga variants ng SARS-CoV-2 na dumarating dito sa ating bayan.
Nagpapasalamat ako sa PGH for a very organized vaccine rollout.
UP PGH was the very first, so none of the other hospitals were willing to inject until Director Gamble Gaspi had his injection. So that was really historic. He was the first person in the Philippines to have a legally approved vaccine injected into him. And then we followed. So I'm very happy. I'm very happy that people are finally realizing that the best vaccine is the vaccine that is already here. I do hope everyone, when they are told that their vaccine is ready for them, that they will go ahead and get vaccinated.
Sa aking palagay, bakuna lamang ang makapipigil sa pagkamatay ng 100%, lalong-lalo na sa madaling panahon ay dapat kuhanin na. Ito lamang ang paraan para makaahon tayo pare-pareho sa pandemyang maraming buhay na ang inagaw, lalo na sa aking mga kapwa-doktor, kapwa-guro, mga nurse, mga lolo't lola, kapatid, nanay, tatay, at ilang bata.
We are now seeing a light at the end of the tunnel. Truly, talagang kita mo na yung dulo ng tunnel. Parang matatapos ito. We will be able to end this pandemic as long as everybody is given the vaccine.
Magpabakuna na po kayo.
Huwag na po kayong mag-alala. This is a responsibility for ourselves, our family, and our community. Sama-sama po tayong magpabakuna.
Thank you very much. It's Chancellor Menchit Padilla, EVP, UP EVP Ted Herbosa, and UP College of Medicine Dean Charlotte Chong were among the first who got vaccinated. And truly we are hopeful, but we will be more hopeful if there's more money that goes into paying our frontline workers. And that is our topic today. Pakikinggan po natin ang isang dalubhasa po sa economics. Pag-uusapan po ang hindi man bakit, no? Pero paano napakababa ng sweldo, ng sahod ng ating mga frontliners? Kasi nakikita natin ngayon na napakahalaga ninyong lahat. You are all very important. And yet, the resources that are going into healthcare is not enough. So we're going to talk about that today. So over to you, Raymond.
Thank you. Nagulat po ako dun sa ating opening video.
Medyo touchy.
That was a pleasant surprise, and hopefully that will inspire all of our attendees who are joining us via YouTube, joining us via our live streaming sa Facebook po, who are also wanting to be able to watch this via the playback. Sana po ay mas ma-inspire po kayo na magpabakuna kung hindi pa po kayo nagpapabakuna. But for those who are joining us for the very first time, ang ating structure po ng ating webinar, obviously we will have our main discussant followed by short actions from expert panel po, and then we will go on to the Q&A, and kaya po na nakaagulian po natin nitong mga recent na mga webinar episodes po natin. Meron po tayong mga tatawagin na from our audience na magbubukas po ng kanilang video and will be able to ask questions ng live po sa ating webinar. May we have po our thank you to the very hardworking team and always nagsusurprise po sa atin. Those who comprise the Stop COVID Deaths webinar series team, maraming salamat po. These really are our siblings na po, no? And hopefully we continue on to provide value, to provide meaningful information to all those who are watching us wherever you may be, kung nandito po kayo sa Pilipinas o nasa ibang bansa. Over to you, Dr. Susie.
Well, thank you very much for that, Raymond. No? I think our topic today, while it's about health systems, very important. And next week, babalikan na naman natin yung vaccines at COVID-19. Although this is very relevant to COVID-19. No? Kasi, parang it's gonna take some time. It will be a big effort to do the vaccination. So we just want to make it, make it known that there are issues in the system that need to be addressed. Okay, go ahead, Raymond. I think people want to know about these certificates.
It's okay. For those who continue to ask po ang mga certificate po natin, as of today, all certificates, or at least those who are eligible to receive certificates po, ay naibigay na po for all webinars from 1 to 42. So if you feel that you are eligible, should have received an electronic certificate alongside a copy of the presentations, please let us know. There are those who are also clamoring for perhaps a change in the name. Like we have mentioned in our previous webinars, please be very careful on how you input your name in the registration link, because it's automated po, and that will be how it will be reflected in the e-certificate. As long as you have spent at least 50% of the webinar duration, mabibigyan po kayo ng certificate. Okay, Dr. Susie, let's start.
Okay. Sige, babatiin ko lang, Raymond, yung mga taga Rizal Medical Center ngayon daw nag-start ang kanilang pagbabakuna. Go! Nice. Diba? Fight lang tayo. The vaccine is safe. You can use it. And we really have to just be united on this. And I'd like to greet also, we have some people, Raymond, from outside of the country. You have a rundown of that? Parang may nakita akong Taiwan. So, kamusta po kayo dyan sa Taiwan?
Yes, Taiwan. I think I saw that already. Yeah.
Kingdom of Saudi Arabia. No? What else, Raymond? Who else do we have?
Well, we have those who are joining us, internationally po. I think our attendees po from, let's say, the Niagara Falls, our regular attendee, Niagara Falls, Ontario, Canada. One from the Middle East, specifically Abu Dhabi. There are those from Dammam, Saudi Arabia, Doha, Qatar, Dera Ghazi Khan, Pakistan. I think that's the first time from Pakistan. Also from Bandar Seri Begawan in Brunei, Jakarta, Indonesia, and Petaling Jaya, Malaysia. And also, very first time po ito I don't know how to pronounce this. I think it's Omag or Oma, Northern Ireland. So nandun po tayo sa United Kingdom. Napapanood din po. Maraming salamat po.
Okay, and we are also being joined by many regular listeners from the Department of Education. So welcome po sa inyong lahat. Okay, so we're now going to our opening message, and we've got a very special guest who was formerly the National Statistician of the Philippines and was head of the Philippine Statistics Authority. She is currently Vice President for Public Finance at the University of the Philippines. We'd like to welcome Dr. Lisa Bersales. Dr. Bersales, Ma'am Lisa, welcome to the webinar.
Thank you very much, Dr. Susie, Dr. Raymond. It's really my privilege to give this opening message to this very important discussion. Parang ito talaga straight to the stomach or to the heart of our frontliners. Kaya maganda siyang pag-usapan. Nakita po natin sa video kanina na noong March 1, una pong nabigyan ng COVID-19. Ng vaccine against COVID-19 yung ating mga frontliners, specifically sa PGH. So in my mind, that's really great recognition by the country of how they are so important to us now. They were most important to us also before, but now with the pandemic, talagang kailangan natin sila. So in my mind, great recognition to give frontliners the first vaccines. However, our webinar is asking the question, in my mind, hanggang doon na lang ba yung recognition na magta-thank you tayo, tapos bigyan sila ng vaccine una. So, importante naman yung compensation. So, ako talaga gusto ko siyang nalagyan ngayon ng importansya sa webinar series ngayong umaga. Gusto ko lang kung ilagyan din ng context yung ating discussion. As coming from statistics and specifically from official statistics before, meron po tayong magagandang na produkto ng datos at impormasyon na binibigay ng Philippine Statistics Authority. Meron po tayong tinatawag na System of Health Accounts. Ito pong System of Health Accounts provides a standard for classifying health expenditure according to 3 axes: consumption, provision, and financing. The Philippines subscribes to the standards set globally of coming up with a system of health accounts. And actually, we have regularly reports from the Philippine Statistics Authority on our Philippine National Health Accounts. Nabibigyan po tayo ng report on economic growth quarterly. Pero ang contribution ng health sector sa economic growth, nandun po siya sa tinatawag na satellite accounts. Gusto kong, in my mind, our discussion now will focus on one aspect of our health accounts. This is the aspect of provision. Yung ating health workers, they are the providers of our health services. So in the report of the PSA in 2019, meron silang sinasabi tungkol sa inputs nung health sector in producing goods and services or activities covered by the health sector. Ang rich po ng information na makikita natin dito sa health accounts, and you can always go to the website of the Philippine Statistics Authority. But I focus on the main report where in 2019, pre-pandemic, the country's health expenditure reached 792.6 billion pesos in 2019. This was 10.9% higher compared to the previous year in 2019. So pre-pandemic pa lang po ito nag-increase na by almost 11% yung health expenditure ng kabuuan in the whole Philippines.
VP
So,
Lisa, are you supposed to share your screen po ba, ma'am?
Well, I can share my screen.
Sige po. Sige po. Baka po mas ano po. Yes, ma'am.
Sige po. I'll do that. Thank you very much. So I believe you can see now. This is actually coming from the website of PSA. I just grabbed. So in this report of the national health accounts in 2019, makikita po natin na talaga pong umakyat yung health expenditures. Current po ito ha, in current pesos. And also health expenditure, total health expenditure increased by 7.9%. Pero kasi po gusto kong itutukan yung, if you don't mind, I will skip because I know that our distinguished speaker and the discussants have more to say later. I just want to focus on this part of the report where itong factors of provision, ito yung sinasabi, sino ang nagbibigay ng ating health services. So sinasabi dito that in terms of growth rate in 2019, and I'm looking at the second paragraph, compensation of employees grew faster. Umakyat naman po ang compensation of employees in the health sector. And it says there, however, that mas malaki yung share ng growth doon sa tinatawag na materials and services used. Ito pong pink na part. So ang bulk talaga ng spending for provision ay napupunta dito sa mga materials needed for healthcare. Ang compensation, ito po siya yung blue. Yan yung share niya. Ang next ay consumption of fixed capital. If you will look at that, ang liit-liit po. Ito yung mga infrastructure, yung mga equipments, and to support the health services. And other, there's the green one is just an aggregate of all other expenses for factors of provision. So makikita po natin na pre-pandemic, umakyat naman po ang compensation. But the question is, sa ating webinar ngayon, sapat po ba? Meron pa po tayong isang product ng Philippine Statistics Authority. Ito po yung annual survey of business establishments, of Philippine business establishments. And I will not show anything there. I would just like to report to you that which institutions provide healthcare for us. Nako, ang bulk po talaga ng nagbibigay ng healthcare services ay hospitals. Nasa kanila po talaga, nandun po ang ating health workers sa hospitals. Next po ay yung mga dental services, clinics, yung other frontliners. So yun yung nakikita na datos doon sa annual survey of Philippine business industry. But I would like to focus on one statistic that I saw there, where in 2017, sorry po, 2017 lang yung nag-grab ko from the website. It says there that in 2017, yung ating pong annual compensation of paid employees ay on average 232,000 pesos. So that's about 20,000 pesos per month on average. So 2017 naman po, pero noon yun. Pero ngayon, I don't think na umakyat siya masyado, no? So I believe this is the context of the discussion where sapat ba yung compensation na binibigay sa health workers given that they give so much to us. So my message is that there are data that show us the situation of the health system as well as our frontliners. Now, I will say something personal. Nung last Wednesday, ako po at saka yung aking asawa ay nagpa-lab test for general check-up. I'm so blessed, hindi ko masyadong nagkakasakit. Pero every time I have engagement with our frontliners, like the medical technologists that draw blood, the technicians who got my X-ray, naku, ang galing-galing po nila. Iba po talaga ang bedside manner ng Pilipino. Ano po? So I really appreciate our frontliners. Now, naku po, itong ating mga magsasalita ngayon, bound na bound po ako. Siyempre, bound na bound po ako sa ating main speaker, Dr. Ernesto Pernia. Kasi boss ko pa siya dati nung nasa Philippine Statistics Authority. Ako at siya ay secretary ng Socio-Economic Planning and Development. So, to end my message, gusto ko sanang i-quote siya, si Dr. Pernia, sa kanyang pinaka-latest na book, Virtuous Impatience, What Our Country Needs in this fast-changing world. So the context really is this pandemic. And in one of his essays in this book, which was actually published by the Business World on November 26, 2012, but for me, this essay is still so relevant. He wrote, "A question that has nagged even ordinary folks is why our country has lagged so far behind its Asian neighbors. The answer may partly lie with our highly elastic patience. What we probably need is virtuous impatience or a strong sense of urgency. This discussion is urgent." Compensation to our frontliners. Marami pong salamat. Good afternoon, everyone. Thank you, Dr. Raymond, Dr. Susie.
Thank you very much. That's Vice President Lisa Bersales of the University of the Philippines in charge of finance. And yes, indeed, we are going to have a very important speaker who's going to talk to us about why we need to increase the salaries of healthcare workers. So let's go back to Raymond, because I think you're going to do your
Our regular fun poll. Okay, TVUP, may we have that be displayed on the screen? Thank you. Okay, so the first couple of questions po really will be asking yung demographics po ng ating mga audience before we go into a little bit more technical questions po. I'll just read off what I'm seeing on the screen and hopefully we'll be able to move on to the technical questions. The first question po for our fun poll or audience survey: what place are you viewing the webinar from? So choices po: NCR, Northern Southern Luzon, Central Luzon, Eastern Visayas, Western Visayas, Central Visayas, Northern Eastern Mindanao, Western and Central Mindanao, Southern Mindanao, and then outside of the Philippines. The second question is, what is your line of work? Very, very consistent po. Just like our 3 previous webinars where we started this, talagang marami po ang nanonood from the nursing sector po. But we have ones from the medical field, pharmacy, midwifery, public health, education, legislation, media, at yung ating favorite, ang ating others. So sana po mas mahimay po natin ang others po na ito. We also have those number 3. This is the technical question na po. But before we go on to the technical question, I'd just like to give a rundown of those who have already signed up and really trying to attend. Kasi po, nagkaroon po tayong technical glitch. It was pegged at 500, but hopefully more and more of our attendees are able to join. I'm seeing that we are now numbering, including the panelists, 785 attendees here in this webinar. So hopefully mas marami pa po mag-join at maka-attend. Especially those who are coming in from Cabugao, Ilocos Sur, Danao City, in Cebu, Carmen, Bohol, Mondragon, Northern Samar, and Bais City in Negros Oriental. With the arrival po of the AstraZeneca vaccines and also the continued allocation and distribution of Sinovac vaccines, we hope that all of you will be willing to take the COVID-19 vaccines that are available and will be distributed in your areas very, very soon. For our question number 3, among the 6 major ASEAN countries, which includes Indonesia, Malaysia, Philippines, Singapore, Thailand, and Vietnam, the Philippines has, so please complete the sentence. Number 1, option A, highest COVID-19 caseload. Option B, largest economic contraction. Option C, slowest economy to recover. And option D, all of the above. Okay. Question number 4, our second technical question. The doctors in Vietnam get paid 2/3 higher than the doctors in the Philippines. An overwhelming majority said true. Sana po ay mapanood nyo po until the end of this webinar so that malaman po natin ang if this really is a true statement. Number 5 question, the doctors in Singapore get paid 10 times more than the doctors in the Philippines. Mukhang marami po ang nakakaalam ng sweldo ng mga doktor sa Singapore po. Just based on the answer. And our last technical question, the nurses and medical technologists are the lowest paid among the 6 major ASEAN countries. Also, overwhelming majority at 94%. Okay. I think I'll turn the floor over to Dr. Susie for the introduction of our main resource person.
Okay, so before we do that, Raymond, I'm going to ask the team to put in our Facebook kasi I'm getting some messages that people were not able to enter na. So can we post on the chat box and you can just share it with your friends who were not able to enter how to get on YouTube or Facebook live stream. I think there are more people who wanted. There we go. So live on FB. So please just send that to your friends who were not able to enter. Napako tayo sa 500, hindi nakapasok yung iba. Okay, before we go to our main speaker, we have some interviews from TVUP. TVUP, please go ahead.
Oo, maraming naging workloads nila. Meron akong 2 friends, yung isa ay sa research, kasi nagpa-process ng mga samples. So before, hindi niya yung work. So ngayon lang niya yung naging work.
Oo, sa tingin ko talagang nadagdagan ng kanilang ang kanilang trabaho. Kasi sa dami ng mga pasyente ngayon na kailangan nilang atenan.
Especially yung mga yung mga nurses, yung mga talagang malalapit sa mga patients, yung ganung mga kasi ng trabaho.
Nakakilala ko ang health worker na talagang hindi na siya halos nakakauwi sa kanila.
Konti lang ang trabaho, but we were greatly affected because some of our staff were locked down in their provinces kasi that time nasa vacation leave sila. Others, walang transportation. So ang nangyayari, kahit konti lang ang trabaho, konti lang din na nakakapasok.
Merong mga incentives, like kunyari mag-i-intubate ka, so merong additional costs yun. And I think lang na, I cannot tell about the others pero there are positions na relatively mas mataas ang rates kapag COVID positive.
I work in an outpatient setting, wala ako sa hospital.
Nagmaman po ako ng clinic, yung mga patients naman dito sa clinic, siyempre nagkakaroon ng takot yung mga tao. They're scared to go to the clinic. So
wala kaming masyadong sick visits, so definitely our compensations have been affected. When you work in the hospital, overwork ka, underpaid ka. Sa amin naman, wala kaming masyadong work. Ano pa rin kami? Ang revenue namin bagsak talaga because we don't see enough sick patients anymore.
May hazard pay kami pero hindi siya ganong ka-compensated. Unlike sa government, ang laki ng kanilang hazard pay.
During the peak of the pandemic, kumonti talaga yung mga pasyente for me.
Kahit papaano, we had some basic salary pero not comparable to what we've had before the COVID hit.
Okay, some voices from our counterparts, our colleagues who we asked about kita, sweldo, no? Magkano kinikita. Ang topic kasi natin, dagdag stress sa COVID-19, may dagdag sweldo ba ang frontliners? And you can put your questions in the Q&A box. I'm already seeing some here. And put them in the Q&A box and we'll try to answer them and also get an understanding of what you're thinking, because this is so important as we move forward. Hindi pwedeng katulad lang ng dati, no? Parang sobrang dagdag na stress sa mga frontliners natin, no? And yet hindi pa natin nakikita yung malaking pagbabago sa compensation, no? Whether that's hazard pay, whether that's salaries, and then there are differences between private sector and public sector. So we're going to listen to an expert. Siya po ay isang economist. He's one of the leading economists in the country. He is Professor Emeritus of Economics of the University of the Philippines School of Economics and former Secretary of Socio-Economic Planning at NEDA. So it is my honor to introduce to you Dr. Ernesto Pernia, who will present to us, he'll make a presentation on compensation salaries of healthcare workers throughout the region. Dr. Ernie, welcome to the webinar.
Thank you, Dr. Susie.
How are you?
I'm okay. I'm ready to go.
Ready to go. We're looking forward to getting a hold of your book on virtuous impatience. I think you hit the nail on the head there, no? Masyado tayong natiisin di ba?
Yes.
We really admire all our frontliners, and this web series has been really meant to help our frontline workers. Now, of course, we can't do something about the salaries of the healthcare workers right now, but we certainly must talk about it. And it looks like what you're saying is that kulang ng urgency. Parang hindi tayo, masyado tayong, mabait ba tayo masyado? Paano ba yun, Doc Ernie?
We are patient, we are forbearing, we are very tolerant and uncomplaining compared with our Asian neighbors. And I think we tend to overdo it to our undoing in terms of the economy and our own, personal well-beings.
Okay, so we're going to listen to your presentation, but before that, I'd just like to welcome all those who were only able to enter the webinar now. I'm getting these messages na hindi sila makapasok. Nakapasok na kayo. Dun sa mga iba, i-text nyo na lang, sabihin nyo na pwedeng pumasok through Facebook or through YouTube. Okay, Dr. Ernie, go ahead with your presentation. We are awaiting this.
Okay, so I'd like to show this is my presentation, Health is Economy. Well, this is a very meaningful title because what this notes is that health and economy are inseparable couples. They are an inseparable couple, and so we have to attend to both of them at the same time, not one over the other. And then the subtitle, We Reap What We Sow, has to do with the extent to which we invest in something, say healthcare. That is the extent to which we can benefit from the healthcare system. So that is the title of the presentation. Next slide, please. So this is the structure of my presentation, which you can readily see. So where we are coming from, as you know, we were all in an annus horribilis in 2020. And so how do we explain how we address the annus horribilis? And then how do we move to an annus mirabilis, to a year that is more, will be that year that will be better, will be more auspicious to us and moving towards post-pandemic new world. And then so I have toward the end I talk about sowing to reap in the short run and sowing to reap in the medium to longer run. Next slide, please. Okay, so health and economy are intimately linked. They are, as I said, they are a very intimately, loving couple, and they are interactive. Thus, health is economy, or economy is health. Poor health adversely affects economic productivity, and on the other hand, bad economy hurts health through livelihoods and incomes of people. There is no trade-off between the two. They are equally vital. One does not have priority in essence, which is called prioritas naturae, over the other, except in timing, which is the timing of intervention. In this coronavirus pandemic, given the Philippines' poor health system capacity, intervention should have come very early, like in Vietnam, with lockdown imposed and eased or lifted in a timely manner as the health system capacity improved. Unfortunately, government started late, moved slowly, and was conservative in spending vis-a-vis our ASEAN neighbors, such as South Korea, Taiwan, Vietnam, and Thailand. Next slide, please. Okay, this is, I'll just show very briefly the performance of the economy, and I'll show you the good and the bad of that performance. Next slide, please. This is the good. These numbers really highlight the spectacular performance of the economy between 2016 and 2019, just before the pandemic. The best numbers ever achieved by the country, more or less in contemporary Philippine economic history. In terms of GDP growth, the economy expanded by 29% in 4 years. In 4 years, 29%, and till 2020. So the Philippines was also poised to become an upper middle income country from middle income country in 2020. But this was all spoiled by the 2019 pandemic in 2020. Our inflation was very, well within manageable and very modest, well within target. Our unemployment rate and underemployment rates were at their lowest since early Philippine contemporary economic history. And then we had the lowest poverty incidence also achieved in 2018, only 16.7% from 23.5% in 2015. We had a good fiscal space, and the national debt was, one of the better ones in the ASEAN region, and that is why we got high credit ratings, BBB plus to A minus. And also we were doing our build program, that is infrastructure investment spending, doubled to 4.5% as a share of GDP compared to the past 5 years and even earlier. Next slide, please. Okay, this is the bad part, because this is now the 2020, and as you know, whereas the economy expanded by 29% in the previous year before 2020, it contracted by 9.5% in 2020, meaning that the economy had the expansion of the economy dwindled to 19.5% from 29% because of the what happened in 2020. And these are the numbers on the right-hand side of the graph show the different forecasts of different financial institutions, including the Philippine government. What this tells us is that to be back to our pre-pandemic growth performance, it's likely to be achieved late in 2022 or maybe even in 2023 already, because of the deep recession that the economy went into in 2020. Next slide, please. So this is the current situation. The Philippines has a desirable reputation of the highest COVID-19 caseload in this part of Asia vis-a-vis population, despite the world's longest continuous lockdown. And secondly, the economy the slowest to recover among ASEAN countries. And this is attributable to differences in health system capacity and the government's COVID response spending. Considering its large population, our population is next only to Indonesia, but Indonesia is a huge country geographically. And also we have the highest inequality in ASEAN and the highest poverty incidence. So we really have a lot of homework to do in terms of addressing these issues. And then we have this pandemic that aggravated or exacerbated our conditions. As regards our health system capacity, the Philippines has severely underinvested or undersown the health system capacity. Healthcare workers, medical doctors, nurses, medical technologists, and so on, in terms of the remuneration and welfare. And this is shown in the next slide. And then secondly, we also underinvested in social infrastructure. Social infrastructure is to distinguish hospitals, health centers, and laboratories from roads and bridges and airports. They are called physical infrastructure. We also underinvested in this social infrastructure. And I will also show something in figure 2 and table 4 next in the subsequent slides. Next slide. And next slide, please. Okay, this is the annual salary of healthcare workers in ASEAN in 2020. So pretty recent data. And so you have the medical doctors would be the top line, the top curves there. And then nurses would be the numbers in red and also the line in red. And medical technologies below that. You will notice that we have a higher annual salary for medical doctors compared with Indonesia only. Indonesia is 24 something US dollars per capita. We have 26. But compared with the other countries, we're really lagging behind. But then when we go to nurses, we are really at the bottom. We're really cellar dweller there. We have the lowest. These are yearly salaries. 9,800 something for the Philippines, 24 something for Malaysia, 19 for Indonesia, 19,000, 20,000 for Thailand, 15,000 for Vietnam, and Singapore is way out of line. It's a sui generis country. It's really a city state. And then medical technology is the same thing. We are really at the bottom here also. And being in the bottom is not just a small difference to the next higher. It's really a huge difference. If you can, and then I'll show this in a table also to make it even clearer. Can next slide, please? This is the corresponding table where the data are also, spelled out there for doctors, nurses, and medical technologists. So as I've said, it's really among nurses and medical technologists that we are really at the real low bottom. Doctors, not too bad, but only compared with Indonesia. But compared with other ASEAN countries, we are also miles behind those other countries in terms of compensation for medical doctors. These data are, I think, they're averages for both government as well as private practitioners. Next slide, please. Okay, these are the specialists. These are just these data are just on the Philippines. These are the specialists, and so I think cardiologists are the best paid among these practitioners. So yeah, and so you have the differences in salaries there. And then let's go to nurses. Next slide. Okay, these are the different salary grades for nurses. Kawawa naman talaga yung nursing attendant at level 1, nursing attendant 1. And then it goes, it increases over the salary grades, but it's not really something to crow about. And again, if we had we had only data on other countries, comparable data, then we would also be looking pathetic in terms of what we are doing or what the nurses are getting. Next slide, please. This has to do with hospital beds. Number of hospital beds available per 10,000 population in ASEAN countries. But these are different years. And you can see, again, we are at the bottom. Kawawa talaga. At the bottom. And as I've said, we have a huge population next to Indonesia, and we have high poverty incidence, the highest poverty incidence among these countries, and the highest inequality, income inequality among these countries. And we have this kind of, capacity, hospital capacity. Again, this reflects our neglect, our underinvestment in health system capacity, both social infrastructure as well as human capital in terms of warm bodies providing healthcare services. Next slide, please. Okay, the next slide is just, these are the numbers corresponding to the bar graph in the previous slide. Go down. I'm sorry, not yet. No. Go back, please. You're one slide ahead. Yes. No, these are the hospital beds. So, yeah, Indonesia is the next lowest. Yeah. Okay. And then, so let's go now to spending compared with other ASEAN countries for COVID. Next slide. Bakit matagal ang transition? Okay. Yeah. So this is a graphical presentation of the comparative COVID response spending in ASEAN countries. We are at the bottom there. We are at the rightmost. And the total spending, these are in the numbers are in orange, and then the per capita, the the numbers that the percentage in those numbers in percentages are the spending, total spending as a proportion to GDP, and the per capita numbers are, where the per capita numbers here? They are below. They're below. I'm sorry. The total spending is on top of the bars, and the per capita spending are below the percentages in orange color. Okay, next slide. This will just again just represent. These are the numbers that you saw in the bar graph, and there you are. Okay, the lowest. This is for the whole year of 2020. Okay, and then I just noticed recently that the Philippines in February, so very late, February 2021, ramped up spending by 65%. So instead of 23.11, it's now 38.12 billion US dollars spending. So nag-catch up ang Filipinas, but kind of late, too late the hero. The spending should have been done in 2020, early in 2020. What we did in 2020, we started small, really low spending, and little increments over time. What the other countries did was big bang spending, really bold spending, and that is why they were able to address the COVID crisis, and also alleviate the pressure on the economy. So these numbers explain why we have the highest COVID to recover among Asian countries. Kulang yung natin. The timing really is very important in terms of stimulus as well as in terms of addressing a major health crisis. I don't know why we do it that way. It has to do with the lack of sense of urgency, lack of virtuous impatience. The other countries are more, the culture of virtuous impatience or sense of urgency is much stronger in the other Asian countries. This is something that it's not impossible to learn. It's just a matter of changing the way we do things. It's not a cultural transformation even. It's just that we need to have a sense of urgency. Hindi pwedeng bukas na lang, next year na. Yun ang attitude. Pwede na yun itong amount ngayon. Hindi pwedeng ganon. Next slide, please. The next slide I show is these are the deficit and debts of the different countries. The budget deficit because of the ramping of spending. Talagang tumataas ang deficit at saka yung debt level also. Yung atin again the rise in these numbers or the changes in these numbers were over time, little by little. The others malaki sila, parang as I've said, big bang impact kaagad. Next slide. What has been timid in spending or unti-unti muna, little by little, kasi they wanted to preserve our credit rating sa among major credit ratings agencies, Fitch, Moody's, and Standard and Poor. Okay, but then if you look at the other countries, they ramped up their spending early, really massive, big bang spending, but their credit ratings were not affected. These credit ratings are these are the latest, but if you compare them with in the previous year, they're about the same. Hardly any change. Same thing with the Philippines. So we really lost out. We did not spend as much last year, but we still got the same credit rating. So no advantage in slow spending or late spending. And next, please. Okay, what are the implications? Where we are where we are because we failed to spend or sow or invest adequately in health, human capital, and social infrastructure. Tables 5 to 7 suggest, despite sharply ramping up COVID spending in 2020, the 5 ASEAN countries, other than the Philippines, maintained their respectable credit ratings based on 2019 deficits and debts, implying that the credit rating agencies have adjusted the rating norms owing to the pandemic. The Philippines, therefore, could have markedly ramped up its COVID response spending and still keep its likewise respectable credit ratings. Next slide. Okay, now I'm toward the end of my presentation. So sowing to reap in the short run. Okay, so we need much increased spending. Maybe repurpose some of the physical infrastructure budget to social infrastructure budget in order to increase or improve our health system capacity, more hospitals, better equipment, and so on in these hospitals, in these establishments. And this should include investments to fortify the health system capacity, raise remuneration and working conditions of healthcare personnel, and build or improve social infrastructure, expanding to the provinces. We should have more hospitals, laboratories, medical schools, like PGH, UP PGH in all regions. I think that is one bill that Senator Villanueva is pushing, PGH in all regions. Spending in these areas of concern are long overdue, actually, and they really should have been done because they will magnify the impact on other stimulus measures, such as the stimulus from physical infrastructure, to include digital connectivity, social amelioration program, and assistance to distressed micro, small, and medium enterprises and unemployed workers. Most of these are covered in the accelerated recovery and investment stimulus for the economy, the ARISE bill, which unfortunately has not been passed. And that bill is what we call a demand stimulus. What we need during a crisis like this, like what we have, is demand stimulus, not supply stimulus. Meaning stimulus coming from demand for mga purchases, spending by households, not improving the capacity of suppliers to provide goods and services. And I think there's this bill by our colleague in the School of Economics, who is now a congressperson, Stella Kimbo, who is pushing for another bayanihan free. Next slide, please. So let's now talk about the medium to longer run. We need to strengthen our public-private enterprise partnerships a la bayanihan spirit. As you know, bayanihan spirit means mutual trust and empathy to make them more efficient, but keeping them at arm's length to forestall corruption. Such public-private partnerships will ease the demands on the government's fiscal situation. Government should take a friendly and collegial, not adversarial stance vis-a-vis the private sector. for a unified effort toward the country's development goal. Another bullet is a push for passage of long-spending economic bills, Public Service Act, Foreign Investment Act, Trade Liberalization Act, etc. And then regarding foreign direct investment, we have already trimmed that to the minimum that we could trim under the 11th fiscal foreign investment negative list. The rest have to be addressed by legislation or constitutional reform. By the way, the Philippines remains the most restrictive in ASEAN regarding the entry of foreign direct investment. Compared with Vietnam, Vietnam's economy is 100% open to foreign direct investments. So we also need to vigorously invest or sow in science, technology, and innovation. Philippines spending on this has remained at 0.15% of GDP since 2000, since early 2000, making the Philippines the persistent cellar dweller, among other things, in science and technology in ASEAN. Next slide, the final slide. So we need to recoup lost opportunities from failed population management by fully implementing the reproductive health and the responsible parenthood and reproductive health law, and adequately funding the national program on population and family planning to address, among other things, unwanted pregnancies and stunted children. As you know, we have 0 to 5, among 0 to 5 years of age, stunting is around 33%, 1/3 of children, Filipino children aged 0 to 5 are stunted because of, many of them, unwanted pregnancies, meaning unprepared mothers to be pregnant. And we also have this problem of teenage pregnancies, which is, again, a specter in terms of what the situation is in ASEAN. Because, those other countries, those teenage pregnancies are not a problem anymore. And then, as you know, the birth rate this year is going to increase by around 18%, with around 300,000 quarantine babies due to the thinly spread health services, including family planning program during the pandemic. We also need to boldly invest in the environment and nature protection and disaster risk reduction, preparedness, and management. We need to heed Pope Francis's Laudato Si encyclical on caring for nature, our common home. Second to the last, we need to develop culture or habit of sense of urgency, which I mentioned earlier, or virtuous impatience, so things get done faster. Again, in ASEAN, we seem to be the most patient and tolerant of delays. Mañana na, pwede na habit, thereby making us stubbornly lag behind these other countries. If we do the above and other suggestions from the other speakers, plus from other speakers, we can work on the objective of the Philippine Development Plan 2017 to 2022, which were crafted during my time, post-pandemic, to lay the foundation for inclusive growth, a high-trust and resilient society, and a globally competitive knowledge economy. Thank you very much. And thank you very much for your patience.
Okay, thank you very much. That was Dr. Ernesto Pernia, former NEDA secretary. Let me just open my camera. Here you go. Okay, and gosh, I have a lot of questions. Thank you so much, Ernie, for that presentation. Really an eye-opener for many of us. I've got lots of questions. I think our audience has questions, but I also feel very frustrated, and might venture to say I feel a little angry that we've seen so much suffering among our frontliners, and to know that we could have been spending more, that's a bit painful. But let's take this up later on in the panel. I'm not a reactor, but sorry, I have a reaction. Raymond, let's go to your next reactor. Sino na lang magre-react muna? Kasi medyo nag-emote ako dito.
Sige po. We'll call in, we have an excellent reactor panel for today. We have three in actuality. Let us start with one of the top, actually, health economists in the country. He is a professor at the Department of Clinical Epidemiology at the UP College of Medicine. May we call on Dr. Carlo Panelo.
Thank
Yes,
you
sir.
very much,
You're
Dr.
on mute.
Raymond. If I may just share my screen briefly. So, can I be allowed to share my screen, Dr. Raymond?
Go ahead, sir. Go ahead. You should have sharing ability.
Okay, here it is. So, I'll just like to show a few slides to complement Sec Ernie's presentation earlier. It's an honor to join the forum with Sec Ernie, one of our professor emeriti in the School of Economics where I trained. And he's right in pointing out that we did underinvest in our healthcare system. And this is actually not a recent phenomena. It has actually been several years of underinvestment. As what this slide would show, although I can only go back to 1995 as far as this graph is concerned, but it already shows where we came from in terms of growing our economy and growing the extent of our health expenditures, and our closely compared neighbor, Thailand, already had more than double the size of our economy back in 1995, and their health spending ramped up rapidly over time. We did have an increased rate of spending starting late 2000s up to present, but this is also being tempered by the size of our economy as well. So as our economy grew, our health spending also grew, but it came from a very low base, meaning our economy was definitely a lot smaller. As a result, the system was not actually able to keep pace with the growth of the population and its needs. And the graph on the left of your screen shows the beds per 100,000 population ratio, which actually shows that over time from 1990 to 2014, it actually showed that government beds even declined in terms of the ratio to the population. And whatever growth in the number of or the ratio of hospital beds is being compensated by our private sector. And this actually shows that over time, up until the late 2010 period, we really did not get much investments in the health sector that led not only to a reduction in bed to population ratio, but also in the upkeep of our facilities. And on the right, you see a comparison across regions in terms of the capacity of health centers at the time in terms of their ability to provide CBC, which is actually the most common blood test you can possibly request. Another factor perhaps that could explain our performance in dealing with COVID is the fact that our health system is fragmented in terms of its service delivery and financing structure. What you see here is that there are at least 6 payers or sources of health spending in the country. This was the data set that our national statistician referred to earlier, that there are many players in the health sector, and these sets of players actually make their own autonomous decisions. And in particular, I'd like to emphasize that while healthcare spending grew over time and much rapidly since the year 2000, a lot of that growth is actually being driven by out-of-pocket spending, meaning individual family spending for healthcare. And this was quite evident when COVID hit, that the capacity to implement interventions on a more uniform or standardized manner was pretty difficult because of, number one, having to deal with many autonomous local government units that can make decisions on their own, but also that funding for healthcare services flows out through many sources. And in most cases, out of pocket, those that have the means are the ones that are able to actually pay for health services. So thank you very much, and good afternoon.
Okay, thank you so much. We didn't really expect that we'd have a lot of graphs, but very, very helpful po to visualize and just for comparative analysis of the work. Dr. Susie?
Okay, so we've got another panelist. Sorry, let me fix that. Yeah, we've got another panelist. I'm very honored to introduce somebody I've known for a long time. And I was calculating, I've known this doctor for more than 40 years. Kasi siguro we knew each other when we were toddlers now. We were together in pre-med. So I'm very honored to welcome to our program Dr. Carlos Naval. He's an ophthalmologist and he's from the Galileo SurgiCenter. And he's going to give our view from the perspective of the private sector. So Kaloy, welcome to the webinar.
Hello. Hi, Susie. Hi, Ray, and the rest of the panel. Just going straight to this is the micro view. We've had the macroeconomic view. This is more micro. Despite you see the health policies of the government detrimental to the health profession, the health profession remains an attractive career path for many. Many unfortunately use it as a jumping board to greener pastures, no? But many also choose to stay. And unfortunately, because of the lack of infrastructure and economic development nationwide, in rural areas, it causes a maldistribution of physicians. For example, for data that I checked a few years ago, 70 to 85% of ophthalmologists, that means eye doctors, are actually in Luzon. So that remains, that gives about 20% for Visayas and Mindanao. And of those in Luzon, 60% are actually report their base as Metro Manila. So they may go out to other provinces outside of Metro Manila, but their base is Metro Manila. So that just shows the large maldistribution of physicians, especially for ophthalmologists. Then despite an annual production of 40 to 80 board-certified ophthalmologists in the country, the ratio of an ophthalmologist to the general population is 2,000 to 100 million Filipinos. That's one ophthalmologist to take care of 50,000 Filipinos. I think this is partly due to a lack of strategic support for healthcare manpower development, although this is part of the Universal Healthcare Act. No? There are no resources that are devoted actually to fulfilling that manpower development, or the lack of that. Now, as individuals, a good number are attached to government training institutions, despite being in private practice. In fact, some rendering almost free service to train residents and to treat charity patients. Some join civic organizations like the Rotary Club or Lions in doing eye surgical missions, for one. They try to fit the charges and fees in case rates, for example, and no balance billing policies of PhilHealth. But you see, sometimes, like what we mentioned before, sometimes the government doesn't support such moves by the private sector. In fact, the restrictive policies of PhilHealth has reduced these surgical missions. The cataract surgical rates in the ASEAN, that's the number of cataract surgeries per 100,000 population, is the lowest in the Philippines. One is that a lot of doctors are not allowed while all ophthalmologists are not allowed to do more than 50 cataract surgeries a month and only 10 at most per day. So quite contrary to the Vision 2020, which the Philippines is a signatory of, to reduce the cause of blindness in the country. And cataract remains one of the reversible causes of blindness. Yet we are restricting our physicians for fear of fraud. Now, some individuals, some people in private sector will resort to working with philanthropic organizations or individuals to reduce the financial burden of patients. So as was pointed out earlier by Dr. Carlo Panelo, it's that 60% at least are outpatient expenses, despite PhilHealth giving its reimbursement, a lot of expenses are actually out of pocket. And those out of pocket expenses pay eventually for the salaries of the doctors, the nurses, and all the other frontliners. One of the reasons also why sometimes the private sector has to have a huge sort of profit margin is because PhilHealth delays reimbursement. For example, in our center, there's a delay of 60 to 90 days before they reimburse us. So we're actually financing some part of PhilHealth services. So PhilHealth asks us to deduct already the PhilHealth reimbursement at the point of care, but then they don't pay us until 60 to 90 days later. And sometimes you're not even sure of getting paid. Now, adopting new technologies to keep ophthalmic services at par internationally, we're very good at that. And we actually, how do we pay for that? Well, we charge private patients or paying patients higher, and we're actually subsidizing the services for the less fortunate. And then what we can also do, and sometimes many of us do, is go beyond our usual professional borders. Like, for example, I promote vaccination for COVID, preventive healthcare, especially for diabetics, rather than just stick to a specialty and the curative aspects of my care. And of course, one of the things that we can do to contribute to better healthcare expenditures by the government is to pay the right taxes, which is probably quite one of the most unpopular things I'd say here. But paying the right taxes will probably redistribute some of the wages on healthcare so that to equalize or reduce the inequality in our economy. Now, as an organization, the private sector also has a role. Aside from individual members participating in activities I named, professional society should learn to be more politically involved. Now, doctors sometimes mistake being apolitical with being politically apathetic. Being political does not mean being partisan, but have a stand on policies, particularly in health, cultivate a sense of what, as Dr. Pernia says, as he coined, virtues in patients, not remain passive, but reactive and even proactive, hopefully. What I mean by this, participating in government initiatives like the Health Technology Act or the Council, bring out issues with Congress on health development, which we're very poor at. Help LGUs in the use of ERA and the development funds so that it goes to healthcare rather than just other non-productive activities. So I'd like to say that while the government has its failings, healthcare professionals in the private sector and their professional organizations, either by individual actions or group activities, can also contribute to health development. So act within the budget, so to speak. So the very act, I think, of staying in the country is already a patriotic statement by many of our individual health workers, particularly the lowest paid, the nurses, the med techs, even the therapists, respiratory, speech therapists, etc. Taking part in organizational and management initiatives in promoting and making delivery of care more efficient would be one role of the private sector. making more organized and taking a more organized and systematic approach in healthcare delivery, like creating networks to reduce fragmentation of the healthcare system, which actually the coordination between the different healthcare systems is one of the costs of our fragmented healthcare. Getting other means of funding to spur healthcare development as a stopgap measure also works. We have a lot of programs that are funded by NGOs, like Fred Hollow's Foundation, for example, Rotary and Lions, as I mentioned earlier. But these are, as I said, stopgap measures. We still have to have healthcare expenditures increased by the government. So I'd just like to end that by saying that while private practitioners and the private sector have to act according to a defined business model in order to be sustainable, meaning revenues must increase in order for us to increase the wages of frontliners, nurses, illustrating maybe another aspect of the intimate relationship between the health and economy. The government is not so limited. It can borrow much more. It can spend much more. In fact, it behooves the government to take over where the private industry cannot deliver services. However, that is not to say that the private sector is not doing anything. It cannot be a one-way street, though. We can do more. The private sector can do more. But the best way forward for us is through government support implemented in a more holistic approach, not just looking at it on a public health perspective. So thank you for inviting me to React, and I hope to stay to answer questions later on. That's all I have to say.
Thank you very much, Dr. Carlos Naval, who is from the Galileo SurgiCenter. Thank you for sharing that, for sharing your views, no, from the point of view of private practice and what the private sector can do and what the possibilities are. I'm going to turn over to Raymond because we have one more reactor. Go ahead, Raymond.
Thank you, Dr. Naval and Dr. Susie. For our final reactor, we have the special assistant to the PGH director, but he is also the assistant program leader for the Philippine Primary Care Studies Group, none other than Dr. Rafael Marfori. Dr. Rafi?
Good afternoon, Dr. Raymond, Dr. Susie. Thank you, Dr. Pernia, for an enlightening presentation. Actually, Ma'am Susie, I feel like I have to react to all the that's been said because it's all very important to me from my work in both the tertiary level here at PGH and in the primary care research field. We do whole systems research for over 3 years now, and it's helped to inform also our laws. So let me just share a few slides for this. No, it's quite clear that COVID has certainly added new problems, which makes hazard pay an obvious choice. But I don't think that in a single word we can finish this webinar by saying Dagdag Suweldo ba ang frontliners? Dapat, and it's done. But I think COVID also exacerbated long-standing problems, which prompts us to ask, aside from the sweldo na dagdag, shouldn't we also be asking, is that enough? Is that already fair, or are there unresolved issues beneath that sentiment? Because the sentiment underlying this question is that we in the health sector, particularly the people perhaps, have been undervalued even before COVID. And I just want to unpack this without negating the economic aspects of the question, because it's certainly very important. So let's start there from the obvious one of compensate well. And the public sector at least has had some good results here recently. You do things like have a base salary that's increasing. That's from the VP Lisa Bersales' presentation. But successful public hospitals have added a bonus to this. The more workload there is, the more bonus there is to go around. And we copied that model for primary care. Even if the payouts from PhilHealth aren't as big in primary care, we saw good results, at least in job satisfaction, when the workload is commensurate to a bonus. But then this does not explain observations like in some public hospitals where we operate, you have vacancies lasting for years unfilled. And this is a good public hospital that I'm mentioning right now in a relatively progressive and thriving province where the standard of living is quite good. And this is after the salary standardization law. So clearly, the monetary compensation isn't the whole picture. Maybe if we copy from the best employers in the world, you have all those rankings. One of the consistent advantages is advancement or career progress. You know, they nurture you. You have something to look forward to. Maybe it's a promotion or a raise. They develop you and you are involved and you stay in that job. No, so this is an important part of human resource management that I think should apply to healthcare. In my private sector experiments right now, we're thinking of maneuvers like equity or giving a stake, co-ownership, for example, for the in that clinic, so that the doctor or the nurse who is now a shareholder or stakeholder in the enterprise is involved and has buy-in and wants to develop that enterprise for the long term and continue serving that locality or community. But still, a lot of what I've been discussing applies more to doctors, maybe in a way to nurses. But we need to expand the scope of this discussion coming from the COVID experience where we saw healthcare is a team effort. No, yung sinasabi nating frontliners, hindi lang doctors yon. Contact tracing had a lot of footwork house to house, which relied on barangay health workers supervised by midwives and emergency medicine doctors. You have your vaccinators being probably, in all likelihood, mostly nurses. You have your swabbers and the PCR tests being taken and run by medtechs, lab techs. So now you'd be thinking something like, okay, let's compensate the entire health team, compensate the team. Now let's move to team practice, and that's more fulfilling. It will be more rewarding. It's a broader picture now. But here you start to see it's becoming quite unwieldy. This is very costly now just to recruit and retain, hopefully retain. We're not even sure if it will work to retain them. And we haven't even addressed other health human resource questions like the quality of that care, the ongoing development and learning, the medical supplies they need to have a fulfilling and meaningful practice, the data they must collect, and so on and so forth. Because without these supports, it's like asking our health workers to practice in a vacuum. And that is a strong factor for them to leave, to not stay, to not stick around. It's like asking a race car driver to sit through Manila traffic. They won't love that situation. They would rather leave it. They'll walk away. So they need to feel effective. They need to be effective. And at this point, we're starting to see the limits really of this entire line of thinking, which unfortunately, and we're learning this in the global health community, that it's I guess too much of an employment frame of mind. We're treating our health workers just like employees, which they are, and there is a livelihood aspect to this. But my point here is that it's not only that. If you step back for a moment and consider that they're still doing this work, decades into these underinvestments that Sec Pernia has described, we are still doing our work. I think that speaks to an inner motivation or set of beliefs and aspirations that we have to tap into also. We have to harness and in fact reinforce with our own kinds of investments as health planners. And we will get a positive response in a way that maybe salaries aim to get, that kind of response, that kind of fire them up into their job. This is the most humane profession, and if you want to find examples of that, I guess look no further than my professors here, I guess at PGH. It's quite known that many have continued to serve and teach without compensation. A more extreme example, for love of the game, in India, where the village health worker concept was born, the health workers up to today, since the 60s, they do the health part of their job voluntarily. And they are compensated more using assets. They have a peace of mind on the side that they have a patch of land here, some, a grove over there, animals, that their livelihood is taken care of, and they're still passionate about the health work. And they're also given training and trust and competencies from their team as members of valued members of a health team, which in turn spills over to the trust of their patients as health experts in their own right. And they have stayed; they've not left their rural areas. So this all goes back to the economic or employment approach being incomplete. And I'm saying this example from India for a good reason. No? We need to shift our frame of mind from employees only to actually stakeholders in building up the things that have been underinvested. They're all interrelated, as were described earlier. And the way to do this is by investing in them. We don't just have to pay them, we have to grow them. We have to side by side, like build the health enterprise together with them. They are a crucial part of it and they want it to work. So let's make it work so that they can do their jobs effectively. So going back now, so it's incomplete, but it has to be part of it. Let's expand this now. And we like to, in our research group, make this more memorable with a set of E's, 4 or 5 E's. And the next E is to equip or to enable. And some of the things we've done are to give tools like UpToDate. This is a highly respected, very credible, and quite expensive outside of research online resource that doctors utilize. But we gave it up to the level of nurses, midwives, even barangay health workers, and we had some good feedback and good effects. No? So it's quite groundbreaking. Our electronic health record system, we designed this with their workflows in mind. We designed it for the entire team. So the users of this single system that we've developed are the doctor, the nurse, the midwife, the lab tech, the med tech, the pharmacist, the barangay health worker for some tasks. It's customized for them to make health work efficient and easy. The service delivery network itself, this is in the UHC law, Universal Healthcare Law. I regard these as enabling factors because they allow their prescriptions, for example, to render service that would not otherwise have been there. So it's like equipping them with tools. No, the private lab outside, the private pharmacy attached to the network across the street. After they prescribe, the patient can go there and actually get what was prescribed, and it's very fulfilling also for the providers and has good health outcomes, of course. And skills I would categorize as equipping them because it allows them capabilities to do their job that wouldn't be there before. Empower, leveling up a little. Now, how does this differ from enabling? One thing we did, well, let me just outline all of them for speed. You can empower, and I know this is a word that is often overused, has lost meaning, but if you concretize it with policies, team functions, the protocols in place at the workplace, and licenses or societies nod to them to say you are authorized to do so and so, then we're talking about the authorities that are within their scope of power now to render to their patients. So for example, a policy like, actually let me do this in reverse. Assume that we have nurse practice in the Philippines. A good example historically is China with its barefoot doctors, they were called. I mean, look at the economy of China now. By investing in barefoot doctors in, I think, the 70s, I think they proved the thesis of Sec Pernia that economy is health. But I fully believe that our nurses are probably far more competent than those barefoot doctors. Filipino nurses are amazing, and the barefoot doctors, I think, were only given certain types of training. Regardless, now, so assume that we have nurse practice and they could prescribe things, they could diagnose things within their scope, properly trained through curricula that have been vetted by CHED. That is an empowerment example. And with that, you wouldn't need, because we don't have that, we had to invent instead a team function of approval. So our electronic system allows the midwife or the nurse in the barangay station to prescribe something electronically, to diagnose something electronically, even if their license says they can't, because the electronic system safeguards them from printing that or finalizing the record. Meanwhile, the doctor will look at that same electronic record far away in the rural health unit, maybe in the city, and look at the entire clinical record, and it's as if they're working on the same chart. He will approve or she will modify it or send it back electronically, and only at that point can they now print this as a prescription. And this is an empowering function. Not to mention that the patient gets services right at the barangay level as if the doctor were there. And this now allows policies that are also empowering, like for patients to be told you have to go through the barangay station first, because we don't want to skip that level when we would be flooding the city health office or the rural health unit. If we all skip the barangay level, we skip the nurse, and there's only one doctor for 30,000 people. So these all work together. Empowerment, no, just allow me to linger because it's something that's gas, but I don't think it should be. And let me just take a side trip here, because there are now implications if we think this way on another gas term of capacity building. These are all capacities at the individual, group, or societal level. And finally, an emergent property, I think here, and I'm near the end already, is with all of these, we would get an endearment of our health workers to the public, maybe to policymakers. They will be held in higher regard because they are effective, they're inspired, they are capable, higher esteem, entrusted with greater responsibility, even at the lower levels outside of hospitals, where the funding is hardest right now, and tightly integrated and valued within the health systems that they serve. So how does this translate into policy? Just briefly, I think it implies that we need to have a more comprehensive approach and use a more holistic framework. We cannot just reward our health workers as economic beings when they are functioning and proving to us how much of human carers they are. Let's support them in their work in a total way, health systems-wise. I think it implies brave new regulations and licensing. The obvious example is nurse practitioners, of course, with proper safeguards and curricula. And that now implies that we need also reforms in education, professional education that leads to this cadre. I think it implies that we must target decisively. We know the root causes. I've tried to trace them briefly here. We should take aim specifically at those root causes, particularly for doctors because they're so difficult to attract to the rural areas, as Dr. Naval was saying. But it will take too long to develop the rural areas until doctors and nurses gravitate there. So I think our better option would be to rotate them and to be creative about this. Follow the example of oil rigs as just an example, a theoretical example. In other words, limit the dosage to the hard areas, difficult areas. They don't have to permanently stay there, but by rotating them, keeping them in touch with the cities and their colleagues, they also don't permanently leave. And my personal favorite, recruit the right med students in the first place, because with those proper motivations that I mentioned earlier need to be harnessed, I think we've won half the battle, and the rest of it we can is less of an uphill battle to win with the compensatory mechanisms. And just to echo other speakers talking about the private sector, the maneuvers I've described, I think you need less red tape than government to do them. And the private sector has that maneuvering space. HR management is probably much faster there. So yes, I am calling for innovation. We are moving already as a country from deployment to employment, or hopefully. But I think I've been calling for a movement beyond employment also to something a little more comprehensive with enablement, empowerment, and endearment. And all of this is grounded on a view of health workers as more than employees. So the compensations should be about investing in them as stakeholders in the health system. So thank you. And I welcome the questions also in the discussion.
Thank you very much. That's Dr. Rafael Marfori, who I think gave us a very fresh perspective on how to think about compensation, that it's not about money and getting paid, but it's about professionals who are actually drawn to service and who are actually dedicated because they have a calling. No? Okay, we're going to call everyone back for the panel. Let's call VP Lisa Bersales, Dr. Ernie Pernia, Dr. Carlo Panelo, Dr. Caloy Naval, Dr. Rafael Marfori, and I understand Executive Vice President Ted Robosa is also with us, and we're they're all putting on their cameras. Okay, so while we're putting that on, Raymond, can we let our panel know who is in the audience?
Okay, so right now we have people who are interested po to us, and just like po sa nakaugalian po natin, we have a pharmacist who is helping out po, ask the questions, ang ating mga talagang umaating pong mga question. I think her name, let me just pull it out po. I think her name is Sarah. She's from the Philippine General Hospital po. May we have Ma'am Sarah to ask the first question from the audience?
Good afternoon po sa inyong lahat. So, I am happy po to have this opportunity to join you in this webinar. Usually, pag sinabing hospital or healthcare, we always have in mind doctors and nurses, no? And rarely we mention the pharmacy. So I am happy na I was given an opportunity to be with you para kahit paano makita rin naman na may mga pharmacists din na involved sa healthcare. So as Dr. Bersales mentioned earlier, that we can give recognition to healthcare workers. So I think it's high time that the general public, example the media, will also be aware that the healthcare does not only comprise the doctors and nurses, but also other paramedical professionals. Okay, so nung nagle-lecture si Dr. Pernia, no, medyo nalungkot ako doon sa mga statistics na kanyang mga binigay because of yung kino-compare tayo with the other Asian countries. So really no, lungkot na marami tayo when it comes to population. Siguro when it comes to working force, mas marami ang Pilipinas compared dito sa mga ito. And if you think of working force, andoon palagi ang tax, di ba? So, ang question ko, why is it that as in spite of the big population and the big working force in the Philippines, bakit maliit pa rin ang ibinibigay na pondo sa ating healthcare budget? Ilan po ba ang pwede kong itanong?
Sige po, isa-isa po muna, ma'am. So we could go through the whole question po, Ma'am Sarah. Thank you so much. So, Ma'am Sarah po, although she's from the Philippine General Hospital, she represents only a fraction of our healthcare workers. And as you can see from our poll audience survey, there are those who are attending right now, more than half of them from Metro Manila. The next will be from Northern and Southern Luzon, and also and then the next is from Central Luzon, Western Visayas, and then Southern Mindanao. So we hope that is something that would really encompass the general sense of, how do I say this kindly, general sense of maybe frustration from our healthcare workers po, as it relates to this topic. And maybe we could start the ball rolling. Go ahead, Dr.
In the interest of time, let's also get the other question and then let's have a discussion. So, so the question was, bakit napakaliit ng ginagastos, right? So let's go to our other member of the audience wants to get a question. So let's hear both questions and then let's have a discussion as a group. So let's introduce our other member of the audience.
Okay, so I think we have someone from it's Dr. I believe Dr. Sumalinog po, who has the most upvoted question. Can we have her open her video so she could ask her question po to the panelists? Dr. Maria Ana Fe Sumalinog. Okay, so it doesn't seem that she's opening her video, Dr. Susie.
Okay, so I think let's go ahead and have this discussion. Why are we spending so little? And I think just to get the discussion rolling, I don't think this is something we haven't thought about before, right? So I think my question would be, why is it so difficult to make changes like this? What makes it so difficult to have change? Not like we haven't tried. I'm sure Senator Pernia has tried very hard. Ted's on the panel as well. Rafi, you've been working on the ground. Why is it hard to make changes?
Yeah, well, I think the question has to do with why are we not spending enough? We have a big population. Well, precisely because we have a big population and we have a smaller GDP, or in other words, kasi GDP, or gross domestic product, is like a pie for the family. If your pie, your cake, or suman, whatever it is only so much, and you have so many children, talagang mahirapan makabigay ka ng sufficient portion to each one of them. Kasi for example, our national income or GDP is, I think, about 1/2, or I would say 60% of Thailand. But Thailand has only 68 million population. Tayo, we have 110 million population. So paano yon? So talagang mahirap. Mahirap ka makabigay ng tamang yung gusto ng isa, whatever each one wants or deserves. So it's a very simple thing. 68 million versus 110 million. And the pie, the national pie of Thailand is bigger than ours. It's about, as I've said, it's a little less than double our national pie. So talagang Thailand will be better off. Thais will be better off than Filipinos. It's a very simple, very very rudimentary example lang to make it understandable.
Yeah, we have some of our panelists who want to talk to each other. So we're going to ask EVP Ted to make a comment, and then Rafi Marfori. Go ahead.
Thank you. No, the question is very unique, and I will share my experience when I was Undersecretary of Health. And of course, as part of that, we joined the National Economic Development Authority, which plans our economics, where we will spend. So the NEDA has this big plan for each administration. I was in the previous administration. And I saw there that health was lumped together with social services. I was fighting for health to have it specific because of the changes we wanted to implement. And all these things that Secretary Pernia actually talked about needed to come out front. It needed to float out, but it's not floating at the levels of the National Economic Development Authority because it is hidden under all the social demographics. And I'm sure Secretary Pernia will. So I was fighting for that. I was attending all the meetings. I was fighting for it. And until we have more economists that actually realize that health system is a very complex thing and is closely related to economics. In fact, there is an economic index they call the Human Development Index. And it looks at, number one, average length of life years lived, which is your longevity of your people. The second is the level of education that your people use, which is, I think, is, although education, it's health related because people are healthier if they're well educated. And the third is their economic, the way they can earn money, how much they can earn money. So with that index, talagang dapat ma-focus natin, mapalutang. Now, many of our colleagues have pushed for the UHC. So we're in a dynamic process now. We passed the UHC law, we passed the IRR, but suddenly COVID hit us. So COVID created this environment na pinakita yung lahat ng gaps ng health system natin. Lumutang, kaya pasalamat ako sa COVID. Lumutang lahat yan, the pay of our doctors, the gaps in the infrastructure, and now we need to replan kasi I think the old plan needs to be revisited, and we need to replan in the new normal. And I really welcome your group for taking on this problem of health and economics. Thank you.
Rafi.
Yes, Ma'am Susie. So, very provocative question. So, pardon my response. But to be very frank, I think change requires power, and that brings us to. I'll try to avoid being political, but we've had several decades already where the health just wasn't the priority. But this brings the question of we have to trace, the whispers of power now. And I'm raising this because I see hope, not because I'm not raising this out of despair. I'm seeing changes like at the very extreme. Do we still need government when power is devolving to the cell phone? Just to be tongue in cheek about it, but to give a hint of where alternatives might lie, where we can still have safeguards and channel through other means of power what we want, what we've always wanted as a health sector, because we're quite strong naman. Second, as you said, I work on the ground, and when UHC was the priority before COVID hit, we've been talking as a university to various governments because the UHC law devolved finally resources to the local governments. It's been commonly said that the LGU code devolved the health system in terms of responsibilities and managerial roles without devolving the resources to carry out that responsibility. And I think one thing that the UHC law achieves would be to actually devolve those resources in some form. And so, riding on that tide, we developed a technical assistance program. What I saw in my talks with different LGUs is really that's another alternative. I saw provinces that are acting very fast. One in particular has invested at least 1.5 billion in infrastructure alone, and the others also in their own right. Versus others naman with slower progress, or you'll see it in the news naman if there's corruption or what, and it gets reflected again, going back to Sec Pernia's thesis, as things like the indices of health there or the response to COVID. So there are alternatives, I think, technologically and socially. We need to get ahead of it, otherwise the trolls will win. And there are also institutional, I think, alternatives if we want the power to make these changes.
Yeah. Just going to, Kaloy, you mentioned a lot of things that need to change. What do you think is keeping us from?
Well, I think one of the things that you see the difference, because I treat some foreigners, for example. For them, if there's no health insurance, there's no health. For them, health should be free. They pay 20% copay and they complain. But in our society, you see 60%, 50% out of pocket. You go to government hospitals like PGH, East Avenue, you still have to shell out a large amount to get the healthcare that you deserve. And yet we are so used to that system. We are so passive. We're so used to paying for personal healthcare that it's people are just so like Dr. Pernia said, so patient, so forbearing. And I think that has also to change. Since we are signatory to the fact that health is a right, then our citizens should have the right to demand government to spend more on health.
Carlo, you've worked in the Department of Health a couple of times. And you've seen some health secretaries, undersecretaries, directors try to do things differently. And what happens to them when they try to do something bold?
Of course, it's not easy to change a bureaucracy because there is a sort of like a culture that you have to swim against as a current. And I recall our earlier conversation before this webinar started that there seems to be, such kind of an attitude pervasive in the public sector, not just DOH, that this is already okay, and our citizens cannot demand for anything more. I'd like to go back to the point of spending earlier that was raised, and I agree with Dr. Pernia that I think the primary constraint really is that we can only increase spending for health if our economy also grows, and there is that binding constraint there to begin with. But there are also other aspects of healthcare spending that needs to be understood and worked on. And I would like to point out that apart from the issue of not having enough money, is being able to prioritize where to spend the available money. And this has been an issue that has hounded the health sector, the DOH, and PhilHealth as to what healthcare services to prioritize and which segments of the population to prioritize in terms of available government subsidies. And sadly, we have been spending our government subsidies almost equally across the population and not really providing preferential treatment to the poor. So at the end of the day, it's the poor that actually gets the least of all health services. And even if you are able to prioritize properly, there is also this issue of the capacity to spend. The Department of Health's budget has increased by more than 5 times since 2010. But the average spending is roughly around 60% per fiscal year, of which it's a low number, but actually about 80% is obligated into contracts, meaning it has already been bidded out and there are services forthcoming. But since these were not delivered within that fiscal year, they're passed on to the next. And in the same thing essentially happened with available COVID funding, which is, I think, why Dr. Pernia also mentioned that we spent quite little and quite late compared to our neighbors because our system was also unable to immediately absorb the available funding and are actually still struggling to spend whatever Bayanihan 1 and Bayanihan 2 has generated, which is why the question for Bayanihan 3 remains hanging. Over.
I mean, VP Bersales, you've been working on statistics, and Carlos just raised the point about there's money, but it can't be spent. So if we're looking at, is this a problem that's unique to health? You've looked at statistics of the country, and you've looked at the national health accounts. Is this a problem only in health, or in general, all sectors are not able to spend the money?
Dr. Susie, it also covers other sectors like education. As Dr. Pernia said, it seems that the government is underspending. What I see from statistics are education and health. And in fact, we now have a multidimensional poverty index. Hindi lang siya yung poverty line na income-based. This multidimensional poverty index measures deprivations of Filipino families. Saan poor ang Pilipino sa access to services. Number 1 po sa basic education. Siya yung number 1 na most deprived ng Filipino families in the sense that only half of Filipino families have at least 1 high school graduate. Pero alam ko po na ma-address na yan ng K-12, ano po. Pero at the time na kinuha yung datos ng mga 2018, ganun po ang sitwasyon natin. Only 50% of Filipino families have at least 1 high school graduate. Nakakaiyak, di po ba? So yun. And the next po after education is health. at napaka-pervasive ng statistics na out of pocket pa rin po talaga ang source ng mga Filipino households to spend for their health. As all of the discussants have said, hindi po siya linear problem, itong compensation for health workers. It's really a complex interaction of all of these issues. Kaya siguro po hindi pa nangyayari yung call for better compensation kasi kabit-kabit po yung problema. So yun po. But as because the pandemic has brought to fore itong ating problem sa health, in my mind, as Dr. Ted said, na medyo magpapasalamat din tayo sa COVID-19 kasi nilabas na yung problema sa health system. So I believe this is the time to be impatient.
Great. I think we're on the precipice or at the edge of a cliff where we can really make a difference. We can take that leap and get to a better healthcare system because of what COVID has done. But this opportunity, this window might close if we don't rally the troops, if we don't get people together, if we don't shout out in a louder voice, and if we're not impatient. Okay, we're at the top of the hour, and I'm very mindful of your time. Very grateful for all our guests. Raymond, do we want to just quickly answer the questions on the opinion poll?
Okay, thank you, Dr. Susie. So for the first question for the opinion poll, this is the first technical question. Among the 6 major ASEAN countries, Indonesia, Malaysia, Philippines, Singapore, Thailand, and Vietnam, the Philippines has, which po is the correct answer? Option A, highest COVID-19 caseload. Option B, largest economic contraction. Option C, slowest economy to recover. And option D, all of the above. Who would like to answer po?
So we're going to ask Mr. Pernia. I think he's on mute.
Yes, I think Secretary Ernie is on mute.
No.
Okay.
You're asking, yeah.
All of the above.
All of the above. Okay. Thank you. The next question, the second of 4 technical questions. The doctors in Vietnam get paid 2/3 higher than the doctors in the Philippines. True or false?
True.
Okay. Thank you, sir. Question number 3 of 4. The doctors in Singapore get paid 10 times more than the doctors here in our country.
True
Again. Okay, sir. And then lastly, the nurses and medical technologists are the lowest paid among the 6 major ASEAN countries.
True
again. Okay. Thank you, Secretary Ernie. Thank you so much.
You were asking the person who gave those numbers.
Yes, sir. We just wanted to reiterate that for the benefit of our attendees, sir.
Okay.
Yes.
Sorry.
Okay. So we're going to now ask everyone to just give a parting statement. We're going to start with VP Lisa. Please go ahead.
Thank you, Dr. Susie. Yung parting statement ko po, tingnan din po natin yung regional differences. If we go low-hanging fruit in my mind, pwede po siguro we engage the local government units doon sa area nila. Baka pwede silang mag-ordinance ba yun na magdagdag ng at least for their government workers. So malaki ang problema, but we are all together. Now is the time. Thank you.
Okay, thanks a lot. Dr. Pernia, Ernie, go ahead.
Yes. I think our problem, with the spending is not so much that we don't have the funds, but it was a question of timing when to spend. Kasi kailangan like Vietnam for example, in 2020 was still below the Philippines in terms of per capita income. Ngayon naka-overtake na ang Vietnam, no? Because they grew the only country, the Asian country that grew positive, 2.9% and Vietnam growth in 2020. So, so if Vietnam was able to do, I think among the Asian countries, Vietnam was the best able to handle the COVID, both on the health side and the economy side. So why couldn't we have done that as well? So it was a question of timing of spending. So being smart in when to spend so that it will have an impact on what you are targeting. So, and the other thing is I wanted to say is that, I think we need to have a public-private, what do you call it, a fund, a trust fund, so that this fund can be used to supplement the salary, the basic salary of our healthcare workers. Kasi kulang talaga yung funds from the government kasi marami tayong punduhan. Pero yung kung we have if the private sector provides, say 30% of that big fund, of that trust fund, then it will be more possible for us to improve the remuneration of healthcare workers.
Thank you. Carlo, your parting words.
Thank you, ma'am. As a faculty member of the College of Medicine, what all this has impressed on me is that we can't really overemphasize the need for capacity building, particularly in the public sector, to make it more resilient and nimble to manage these challenges. And COVID is a watershed experience, although the lessons came at a very high cost. And definitely, the health system has the opportunity to actually reform in a way that allows it to become more resilient in the future. And the academic community, UP and other universities, would also need to look at the curricular offerings and the way we train our health workers moving forward on how to be more adaptable to these kinds of stresses in the sector. The compensation to workers is going to be a heated debate, but the fact that it is now being talked about is important, and compensation should be looked at from a broad perspective and not just in terms of the individual professions or specialties. Because as what we learned from this pandemic, it was all hands on deck, and everybody, the frontliners in particular, had to face the challenge head on with whatever resources we have. Thank you.
Thank you very much. Kaloy.
Well, a lot of these changes that are needed are really going to be government initiatives, and government is run by politicians, and politicians respond to public opinion. So I think the private sector and the government sector should all band together and shout out for the demand for health, demand for greater health expenditure, for greater support for all initiatives, both on the local government and national government side, and also for the private initiatives.
Thank you very much. Rafi.
Yes, thank you, ma'am. I just want to draw the distinction between investing in our health workers so they're happy with their pay, and investing in our health workers so they're happy with their calling, their job. I think it's important because it's only when we frame the challenge that way, and that's mind you a bigger challenge than Dagdag Suweldo, because the first question is very obvious. No one will disagree with that. Our health workers deserve better pay, period. But that's too obvious. Frankly, that's too easy, as difficult as it is. But if you frame that challenge that way, that's the only frame of mind that will encompass everything that's been said today, which is this problem's been here a long time. It requires public and private. It goes beyond the sueldo. Even if you address the compensation issue, depending on the model, it might actually, as you said, even I think earlier, ma'am, that It might work better in areas that are better off already, and it will still leave behind the rural areas and the rest of the country because everyone said that this is a complex problem. But with that kind of framing, the criterion is the health workers' own motives themselves. If we can fire them into the job, not just from a pay perspective, but to be awoken by the pay question towards the real, deeper, and complex challenge here, which is they're part of a system. We must invest in them system-wide.
Thank you, Rafi. Ted.
Yes, Susie. Let me start with what Professor Pernia said. Health and economics are intertwined or married. But I would say the politicians are the mistress. So politics is the mistress. And we're in the crux of universal healthcare. We passed a law in 2019. We passed an IRR. Boom, we got hit by COVID-19. We weren't able to implement the IRR and the necessary changes that would have brought about some of these things. But now we're looking at it and we're saying there may be some unintended consequences. A lot of my friends who are doctors or surgeons or have decided to quit medicine altogether. Maybe it's because of low compensation with compared to the risk. What I want to tell the people listening is that you're all in the healthcare sector, you're all healthcare workers. You need to engage your politician. You need to engage your economist. You need to engage your local chief executives. And with that engagement, we will understand how to frame the changes we look at, whether it's a service delivery network at the local health system or at the top level, like us in the university, whether will we educate more people. Secretary Pernia supported us when we said we're going to build a PGH in Diliman. Mahidol University in Thailand, I visited. It's the top it's a top university, but its highlight is medical education. They have 5 teaching hospitals. We have 1. And we're the largest in the Philippines. So the concept really is we need to grow. We can't only just raise the salary. We also have to build the health human resource. We have to answer the infrastructure gap. And we have to fix problems in the healthcare system. So with that, thank you for taking on this topic. I've been trying to insert this in my lessons, but I find that the medical students are not interested in this. I need an audience probably with the practitioners already because they feel these changes. But I think these discussions, this group, I think we should replicate this and keep these discussions going. This is another vaccine. This needs a part 2, I think. Susie, thank you.
Thank you, the CVP Ted Hermosa. Okay, we have, we're past the top of the hour and we're going to ask Chancellor Menchit Padilla to give a brief summary. I know this is going to be difficult, Menchit, but yes, please give us a brief summary of the entire webinar.
Well, thank you. It's been a very good webinar. So it was opened by Vice President for Finance, Lisa Bersales. And I think the message she gave is that there's data and that's for everybody to take a look. And if everyone want to do it, and he has a lot of data, there is data on zeroing on health. And maybe that is the beginning for our audience. If you want to better understand it, let's do that. From Secretary Pernia, we heard it. Health is economy, they're inseparable. They have to be linked and interactive, no trade-offs between the two. And I think, what is important to know is that, just before the pandemic, we were good. We were being poised to become an upper middle income country, but then the COVID came. And of course, now we've got all of these problems. I think, the point that he raised for us to ponder after this webinar is that the current situation is that we had the longest lockdown, our economy was lowest to recover, we have underinvested, we have the lowest salaries for our professions. And we have to ask ourselves now, why is it that we have responded the poorest actually in terms of COVID? So where is the problem? And I think, he capped it by saying that the problem in the Philippines is that we lack a sense of urgency, a lack of urgency, impatience. So in the short run, he said we've got to shift expenditure to fortify the health system, raising the salaries and improving social infrastructure. Medium term, we've got to look at the public-private partnership. And at the end, he goes back in saying that we've got to develop a culture, a habit of saying the sense of urgency and versus impatience. We had a couple of reactors. Dr. Panelo actually agreed that the countries underinvested. He actually showed the graph showing that these were the problems since 1995. We have not even caught up. And the biggest problem we have is that the health is fragmented. And with the increase in economy, increase in growth, of course, followed was the out-of-pocket investiture. Dr. Naval is a practicing ophthalmologist who, from the perspective of a private physician, he said that the problem in the Philippines is that in addition to the lack of infrastructure is the maldistribution of physicians. He just gave his example, his personal experience as far as ophthalmologists is concerned, with 60% being in Luzon, majority in Manila. And, he posed a very intriguing question, and I want to say it. He said, if indeed cataracts remain the main problem in the country, why is PhilHealth restricting the number of cataract surgeries to 50 a month, a maximum of 10 a day? And how can we cope with the numbers if the policies are not strategic? I'd like you sharing about how the private sector can contribute. He said, well, the private sector can help. One, pay taxes, because we can pay higher wages to our health workers. Professional societies can participate. They don't have to be political. They make a stand on health. We should not be passive, but proactive. And he said that, working with NGOs is so critical. I liked his line, and he said, the best thing that the private sector did for the health workers is that we stayed. And that is a major contribution, actually, a major contribution to the country. Dr. Marfori actually gave another framework. He said it's not all about compensating. It's really a question of compensating the team, equipping them, enabling them, empowering them, endearing them. And at the end, all of these measures can actually be translated into a new framework wherein the health workers are not mere employees, but are actually part of the whole system and the whole framework. I guess for the final messages, it's just a few words, one line from each. From VP Bersales said, it's time to look at the regional angle, not just national. For Secretary Pernia, it's not about funds, it's smart spending, timing of spending. From Professor Panelo, he said the academic community need to look at curricular offerings, train our health workers better. From Dr. Naval, a shout out that the private sector will have to work closely with the government sector. And from Dr. Marfori, invest on the health workers so that they are happy with the pay and the calling. And this is the best framing of the challenge. From EVP Ted, he said that, in finding the solution, we've got to engage the politician, the economist, the local chief executive for the better framing of the problem, the challenge, and the solution. So in sum, we are so tolerant of our system. We are so patient. Maybe it's about time. If we say health is a right, then maybe we should demand government to pay. Back to you, Susie and Raymond.
Thank you very much. That's Chancellor of UP Manila, Menchip Padilla. And indeed, I think it's been a great webinar. Thank you to all of our speakers who made the time to be with us today. There's an opportunity. COVID has given an opportunity to show how important health is, and that we cannot continue to go on this way, underspending, under prioritizing, and not providing our healthcare workers, whether it's with material or social support that they need. So this is an opportunity for all of us, and a time to reflect on how we should not be passive, and we need to be impatient. Okay, so next week, we've got a great line of speakers next week. We're going to have a national town hall meeting for hospitals. And again, you're going to listen to Dr. Gap Ligaspi, who is going to be talking about how to continue to keep healthcare workers safe, even if there's a vaccine. Ted Robosa is going to open the program. We're going to have speakers from Cebu and from Davao. Cebu and the Lung Center of the Philippines. So don't miss it. Next week, we're going to do this. Now, we are getting ready for our first anniversary. And in order to do that, we have something special for all of you. So please stay, don't leave. Because after the music and the video, we're going to ask you all to open your cameras, your videos, so we can take some pictures. So bear with us, because we want to have photos of all of you who stayed today. And I guess, Rafi, that's part of endearment. we are going to want to have a photograph with everyone after this. Okay, so I'm going to turn over now to Raymond.
Okay, thank you, Dr. Susie. So ulitin lang po natin, no, yung pong just right after this webinar, pagkatapos po ng kanta at ng video, we will be allowing you to open your videos po so we could take our very first Stop COVID Deaths webinar series group photo. So maraming salamat po sa ating more than 1,150 attendees who are still on the call. And we hope to be able to see you again next week, same time, same channel po. It's been really a pleasure, and we hope to be able to learn more from our National Town Hall meeting next week. So makita-kita po tayo ulit next week, March 12, 12 noon to 2 p.m. We are displaying po the results of our polls, but we hope that you had the opportunity to answer our post-test so that you could gauge your learnings from this webinar. So thank you so much, and we hope to see you next week. It's a date.
Together, let's stop COVID deaths.
So keep safe, keep healthy, and see you online.
The enemy remains unseen. I'll keep your hand in mine. Let's say a prayer one more time. I know you long for home, but I am here, you're not alone. I'll stay with you until the coast is clear. The others pain before my fears, the others laugh before my tears. But right behind the mask, I look into myself and ask, do I have strength to carry on? Oh God, how long must this go on? I need you here to keep me strong. I'm here to hold the line. I'll keep my word until my time. Just look into my eyes and say his name to realize it's fine to be afraid. Just hold on to the word he gave. This time will come to pass, 'cause this salvation's made to last. He'll carry you to see the break of day. The others pain before my fears, the others vows before my tears. But right behind the mask, I look into myself and ask, do I have strength to carry on? But God, how long must this go on? I need you here to keep me strong. I'm here to hold the line. I'll keep my word until my time. The others pain before my fears, the others laughs before my tears. But right behind the mask, I look into myself and ask, do I have strength to carry on? But God, how long must this go on? I need you here to keep me strong. I'll keep my word, your word is mine. The others pain before my fears, pushing on despite the tears. Please take us through another day. Just hold my hand, I will hold the line. I will hold the line.
Okay.
Maraming salamat po. Thank you for staying.